Hi, welcome back to my channel. In this video, I'll be talking about the staging and grading of periodontitis. Now, this is an important question for INSET and you must remember the values. And basically, you were just asked like, this is the probing depth and so on, and now what will be the stage or grading. So, first of all, we'll talk about staging. Now, staging, you need to know that it has three components and you can remember it as by SEC. So, first of all, the first component is severity. Then second is extent and distribution, and the third component is complexity. Okay, now this severity, this is further having three components again, so we'll just write them off. So first is the interdental clinical attachment loss, then we have radiographic bone loss, and then we have the T, which is the tooth loss. Okay, now we'll just divide them into the stages. Now there are 4 stages and you should be thorough with the features of every stage if you want to answer the question. So 1, 2, 3 and 4. Now let's just start. So first of all, in stage 1, the interdental clinical attachment loss is 1 to 2 mm. In 2 it is 3 to 4 mm, 3 to 4 mm, and in 3 it is greater than equal to 5 mm, and in stage 4 it's greater than 5 mm. Okay, now coming on to the radiographic bone loss. Now it is present in the coronal 1/3 and it is 15%, and then in the stage 2 it is present again in the coronal 1/3 and it is 15 to 33%, and in stage 3 it is present in the middle third of root and beyond, and same for the stage 4. Then coming on to the tooth loss component. Now in the tooth loss component, there is no tooth loss in first and second. Then there is a tooth loss of less than equal to 4 teeth in stage 3 and more than equal to 5 teeth in stage 4. Okay, now let's talk about the extent and distribution. So in extent and distribution, you just need to remember one line, that for each stage, if there is less than 30% teeth involved, it is localized, and if it is more than 30%, then it is generalized. And then there is a third pattern which involves the incisors and the molars. Okay, now that's in the locally aggressive periodontitis. Now let's talk about the complexity. Now in complexity, you will talk about local findings. Okay, so in local findings, first of all, you will talk about the probing depth and bone loss. So in the first stage, the maximum probing depth is less than equal to 4 mm. In 2 it is less than equal to 5 mm. Then in third it is more than 6 mm. Alright, then we'll talk about bone loss. Now in bone loss, here in the first one you have horizontal bone loss, same here also horizontal bone loss. Now in stage 3 you have to remember these facts. So in this you have vertical bone loss greater than 3 mm. Then you can have class 2 and 3 furcation involvement, and there will be moderate ridge defect. Now in stage 4, now this is the severe form, so it has all the features of 3, plus there is a need for complex rehabilitation treatment. Then there is secondary occlusal trauma. Then you will see that there is not a moderate ridge defect, there is a severe ridge defect. Then bite collapse and less than 2 remaining teeth. Okay, now this is the staging. Alright, now we'll talk about the grading. Okay, now we are done with this part. Now we'll talk about grading. Now grading again has four components. So first of all, we'll talk about primary criteria. Now primary criteria is based on two parts. So it is the direct evidence, and then we have the indirect evidence. Now what do you mean by all this is that in direct evidence we'll basically see through the radiograph the bone loss and the clinical attachment loss. In indirect we will see the basically the percentage of bone loss per age and the case phenotype. Okay, now I want you to know that in grading we have only three grades. Okay, so we have grade A, then we have grade B, and then we have grade C. Okay, then all of this, then second criteria is grade modifier. Now this is basically presence of risk factors. Now which risk factors? Specifically smoking and diabetes mellitus. Okay, then third component that you have to think about is risk of systemic impact of periodontitis. So this is basically the inflammatory burden. So this is basically you're talking about C-reactive protein here. Okay, and the last one which you will talk about is the biomarkers, basically the indicators of clinical attachment loss and bone loss. Okay, yeah, so let's just go through the first one, which is the radiographic bone loss. So here first of all, in the grade A there is no loss in more than 5 years, then there is less than 2 mm loss in 5 years, and then there is more than 2 mm loss in 5 years in grade C. Okay, then we'll talk about percentage of bone loss per age. So it's like ratio, so it's less than 0.25, then 0.25 to 1.0, and then more than 1 or okay. Then we'll talk about the case phenotype. So in the grade 1 you have heavy biofilm deposits and low level of destruction. Then here you have in grade B there is destruction plus biofilm deposits, like more than grade A but less than grade C. Then grade C is destruction exceeds expectation, okay, and biofilm deposits. Now in grade modifiers in smoking, so grade 1 is a non-smoker, okay, non-smoker. Grade B is less than 10 cigarettes per day, and obviously the grade C will be 10 cigarettes more, like more than 10 cigarettes per day. Then we'll talk about the diabetes mellitus. Now in this, the person in grade A may not have diabetes or maybe like normoglycemic. Then in this one you will have the glycosylated hemoglobin levels less than 7, and here HbA1c will be more than 7. Okay, now inflammatory burden, CRP. See, in this now you have to know that there is a high sensitivity in periodontitis. So you would need to like just know the level. So less than 1 milligram per deciliter, then 1 to 3 milligram per deciliter, and then more than 3 milligram per deciliter. Then biomarkers will basically trace, they will be present in all the grades, and you'll basically like trace them in saliva, GCF, and the serum. Okay, Now we are basically done with all what we need to know about staging and grading, and we'll just go through it once again so that it's thorough. So first of all, we will talk about staging. Now staging, you have to remember that we have 4 stages: 1, 2, 3, 4. Then first is the criteria of severity. Now in severity we have interdental bone loss, then we have the clinical attachment loss, interdental link attachment loss, then we have the radiographic bone loss, and then we have the tooth loss. So 1 to 2, 3 to 4, more than 5, more than 5. Okay, radiographic bone loss, first to coronal 1/3, first is 15%, second is 15 to 30%, then mid, third, and same for fourth. Tooth loss will only be seen in 3 and 4, in 3 more than 4, and in 4 more than 5. Then if less than 30% of teeth are involved, it's a localized periodontitis. If more, then generalized. And third pattern is involvement of the incisor and molars. Then coming on to complexity. In complexity, we have the local things that we're going to see. That is the probing depth and the bone loss. So in the first and the second one, basically you have less than 4 and less than 5 mm, and you have horizontal bone loss only. In the third, you have vertical bone loss, and it's more than 3 mm. You will have furcation involvement, plus you will have a moderate ridge defect. But in class 4, you will have a severe ridge defect, you will have bite collapse, you will have secondary occlusal trauma, and there will be a need for complex rehabilitation treatment. Now coming on to the grading. Now this is like we've done with the staging, and now we'll talk about grading. So in grading, you have primary criteria, then you have modifier, then you have systemic effect, and then you have biomarkers. In primary criteria, you have direct evidence, which is obviously from the radiographic. Indirect is the ratio of the percentage of the bone loss upon age and the case phenotype. Now, if there is no loss for 5 years, now first of all, know that grade is only 3, A, B, C. In A, no loss in more than 5 years, then less than 2 mm in grade B, and more than 2 mm in grade C. Then percentage of bone loss in age is less than 0.25, then 0.25 to 1 in grade B, and more than 1 or 1 in grade C. Case phenotype is basically you have heavy biofilm deposits in all 3, but there's a difference between the destruction. So in grade A, obviously, just common sense, you have low level of destruction, then in grade B you'll have more, and then in grade C it will be more than the expected bone loss destruction. So in grade modifiers, you have smoking and you have diabetes mellitus. So grade A is a non-smoker, grade B is smokes less than 10 cigarettes per day, and grade C smokes more than 10 cigarettes per day. Diabetes mellitus, first one will be normoglycemic or may not have diabetes at all. Then the glycosylated hemoglobin level of the grade B is less than 7, and of the grade C is more than 7. Then in systemic impact of periodontitis, basically there's an increased sensitivity to the C-reactive protein, which denotes higher inflammatory burden. So in first one, it's just less than 1 milligram. Then in second, it's 1 to 3 milligram per deciliter. And then the grade C is more than 3 milligram per deciliter. Then you can also assess for biomarkers in the saliva, GCF, and the serum. So yeah, so this completes the staging and grading of periodontitis. If you found this video helpful, do give it a like, share, subscribe, and thanks for watching.